Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, coming to you from the campus of the University of Oklahoma Health Science Center, and our program part of the Digital Anatomic Pathology Academy from the Digital Pathology Association and PATH presenter. Our case today is a case from the realm of GI pathology. It's a 41-year-old woman who has had progressive abdominal distress for about the last 6 months. She finally comes to attention and is found on radiography to have a rather large, apparently mesenteric mass that seems to be displacing and partially obstructing some of her loops of small bowel. So with that lesion present and an apparent appearance of resectability, in an effort to restore bowel function, she undergoes a resection of the mass. And a representative section is seen here. We can see that this mass is fairly pale pink in color, has a little bit of inflammation associated with it, and it appears to be somewhat extrinsic to the wall of the bowel. It is largely located here outside the loops of bowel, although here in this particular area, we don't see the continuity of the muscle coat, and it appears that the lesion may be somewhat infiltrated into the bowel wall. But it doesn't seem to be particularly based so much within the muscle as extrinsic to it, maybe with secondary extension. Looking a little closer here, we see there's a bit of a vascular background, not particularly prominent, mostly fairly uniform size capillary type vessels. And the cellularity of the lesion is low to intermediate. It looks as though we're looking at mostly spindle-shaped cells with some vacuolar change to the cytoplasm in some areas. And the nuclei are somewhat low-grade, sort of wavy spindle-shaped cells. So needless to say, this prompts us to think about stromal neoplasms that can involve the bowel or the bowel wall. So here's a little additional section, purely mesenteric in origin, and we get a little bit more of this sort of variable architecture with the vascular background. Here a little bit more dilated, sort of small to medium-sized vessels, some areas of interstitial hemorrhage. And then again, on high magnification, we see a little bit of collagenous matrix, a bit of mucoid, mucinous ground substance, but again, fairly low-grade spindle-shaped cells with no particular evident mitotic activity, a little bit of pale purplish cytoplasm on some of these cells. Sometimes more drawn out and sometimes more compressed into wavy spindle-shaped cells. And a bit of a collagenous type of background. Here we see the sort of fibrillar collagenous matrix characteristic of this lesion. So what do we think of in terms of mesenchymal tumors in the bowel? Well, in the mucosal layers, we might encounter the mesenchymal Schwann cell hamartoma. That usually is a small lesion, incidentally discovered. Leiomyomas do occur in the bowel wall, although they're most common in the muscularis mucosa. And again, they tend to be small and so forth. GI stromal tumor and glomus tumor are tumors that tend to be centered within the muscularis. And so these are tumors that generally have their epicenter within the muscularis propria. Certainly either one of them can have a spindle cell morphology, such as we see in this case. There are occasional nerve-derived tumors, peripheral nerve tumors, both benign and malignant, and those can, again, present pretty much at any level, although most commonly concentrated in the bowel wall because of the location of the myenteric plexus. Inflammatory myofibroblastic tumor is a tumor that can occur in a variety of locations, including the bowel, and in that situation it usually involves the serosa. And then also fibromatosis can involve the bowel, more commonly on the adventitial side of things, not usually within the muscularis propria. Finally, it's always good to remember that well-differentiated liposarcoma and dedifferentiated liposarcoma are very common within the abdomen and may occur within the mesentery as well as elsewhere. So, of note, the level of involvement is very helpful in that differential. So there are certain tumors that are more common in the mucosa. There are certain tumors that are more common intramurally. And then there are certain tumors, such as this current case, which are predominantly extramural adventitial. This is an example of fibromatosis, which is a benign non-metastasizing tumor that does have infiltrative capabilities and certainly has a high propensity for recurrence. Intra-abdominal sites are among the most frequent locations, but other locations, including involving the bowel, chest wall, and extremities, are also seen. Typically, this is somewhat more common in adult women in the reproductive age group, but beyond that, it can occur in any age group as well. Importantly, this is associated with familial adenomatous polyposis syndrome, and the commonality here is usually the APC gene mutation. So even in sporadic cases, APC gene may be mutated, but certainly in patients who carry that mutation, their risk of fibromatosis is much, much higher. Now, the CTNNB1 gene also is frequently mutated and hence accounts for the beta-catenin positivity that is seen with this tumor, which is characterized, in addition to beta-catenin, as having positive cyclin D1, calretinin, and sometimes SMA, but will be negative for solitary fibrous tumor markers or CD34, S100 or other neural markers, and certainly negative for the GI stromal tumor markers, as well as STAT6 and MUC4. So here's a representative image from the from the beta-catenin stain from our current case. And the important thing here is, of course, to evaluate the characteristic of the nuclear staining. So while there is some cytoplasmic staining here as well, the key variable to pick up on is that each of these nuclei is staining more darkly than the surrounding structures. And therefore, this is considered a positive stain for beta-catenin with this nuclear staining. So in addition to the morphology that we've seen, I'd like to just give you a little idea of some of the variability that can be seen. This is another example where, again, we see it's located in the adventitia or mesenteric component. But here, rather than that paler morphology with a lot of ground substance, here we're seeing a more collagenous feature with somewhat wavy collagenous tissues. And so just as fibromatosis in the palm or in other locations can have high variable degrees of cellularity, the same could be said of the intra-abdominal lesions as well. I thought perhaps it also might be good to compare with one of the other things that we don't commonly see in this location. And so I pulled a case of inflammatory myofibroblastic tumor for you to compare the findings with that lesion as well. So here again we see that it's sort of an adventitional lesion, this located actually off of the bladder. But as we look at the morphology here, one of the things that stands out to us is that this tends to entrap portions of muscle, and it has a higher degree of cellularity, and there's some degree of mixed inflammatory component to this. Also notice that the cells are a little bit more open, they're more rounded nuclei. They're not the spindle-shaped cells. And mitoses may be a little bit more frequently seen in this lesion, such as here. And of course, the immunohistochemistry will be different with this lesion, more likely to be positive for ALK than the other lesions that we have noted, and also would have myofibroblastic markers, smooth muscle actin, some desmin perhaps as well. So that's a nice tour through our case and the differential diagnosis. Our final sign out is fibromatosis of the bowel mesentery, and we'd like to ensure that they do further evaluation for Gardner syndrome or familial adenomatous polyposis or other APC gene related lesions in this fairly young woman with this abdominal tumor. Well, thank you so much for joining us on this for this episode. If you like this, we hope that you'll comment below on other clues you use with soft tissue neoplasms involving the bowel. And please subscribe. That will ensure that you'll catch word of new releases from our channel. And as always, we welcome your feedback and comments. So click on the link for subscribe, and we'll hope to see you on a future program. Thanks again for joining us.